Hi, today I'll be presenting on oxygen imaging for non-invasive metastasis detection. So 66% of solid tumor deaths are caused by metastasis, which makes it vitally important for surgeons to be able to detect metastasis so they can appropriately plan treatments to optimize patient outcomes. So the gold standard for metastasis detection is actually sentinel lymph node biopsy. And the way it works is you inject this blue dye called methylene blue into the tumor, and you follow the dye through the lymphatic tracts to find the lymph node that it drains to. You then excise this lymph node, send it to pathology, and they look at it and tell you if there are cancer cells in the node or not. However, this procedure is associated with complications such as lymphedema and pain, and it can also miss micrometastatic deposits, which causes some surgeons to continue removing all the lymph nodes in the tumor region, even after a negative biopsy. So there's a need for a more sensitive and specific test that tests metastatic deposits in order to prevent overtreatment and reduce patient morbidity. So in this bottom figure under current technology, I've plotted some of the main imaging modalities that are available to detect metastasis. And as you can see, their sensitivities and specificities lag behind sentinel lymph node biopsy. And the reason for this is because either these imaging modalities only look at the node morphology, which small metastatic deposits won't change the node morphology, or they don't have high enough resolution in order to image the micrometastatic deposits. So we hypothesize that if we're able, because of the hypermetabolic rate of cancer cells versus normal tissue, that if we develop a high resolution imaging modality of oxygen, that we would be able to sensitively and specifically detect metastasis better, if not the same as sentinel lymph node biopsy. And the oxygen imaging method that we are using is called photoacoustic lifetime imaging. And the way it works is initially all the molecules start off in S0 and we pump them to an excited state called T1 or the triplet state. And in this triplet state, we fire a probe laser. And this probe laser tells you how many molecules are in that state over time. So as you can see in the triplet state decay diagram on the right-hand side, we have the triplet state decay shown in green, and we've sampled this decay shown as the green points along the exponential decay. So after sampling these points, we can fit them to an exponential decay curve and calculate the decay rate. And we can use this decay rate to calculate the oxygen concentration as shown in the equation on the left-hand side of the figure. And the way we calculate the oxygen concentration is first we have to do a calibration in order to identify K0 and KQ. While the overall goal of this project is to identify the specificity and sensitivity of PALI in detecting metastatic nodes, we wanted to first start off by quantifying the imaging depth to know what types of cancers our modality would be useful for. And so to answer this question, we took a two-pronged approach where we had simulations and benchtop testing. In both these tests, we had a model where we had a lymph node embedded into tissue, and we measured the consistency of PALI measurements as the depth of the node was changed and its oxygen concentration. So in our physical model, the way we represented the lymph node was with a tubing of methylene blue, which you can see under the phantom picture. And the way we represented the tissue was with a liquid that imitated the optical and scattering properties of tissue. And the reference value we got, for the reference, we replaced that fluid with water. And so that was like our ground truth value. So we can go over to the right-hand results side and we can see the simulation results. And the way I characterized the maximum imaging depth, it was the depth at which there was a statistical significant difference between the reference value and the PALI measurement distribution that I had simulated. And we see that the maximum imaging depth for both is 22 millimeters. However, in our measurements, we see that the maximum imaging depth that I measured was 16 millimeters. One reason for this discrepancy could be because there are secondary reactions that are reducing the population of the T molecules in T1, which reduce our signal and shorten our depth. Another more clinically relevant metric is how deep into the tissue can we accurately differentiate tumor versus normal lymph nodes. And the way we answered that question is I found a paper written by Dr. Becker et al., where they gave their data, and using his data, we were able to find that if a PALI has an error less than 10 millimeters of mercury, we would be able to differentiate with 95% confidence metastatic from normal lymph nodes. And so using the data that we've presented, I've plotted the 10 millimeters of mercury error cutoff in a black dash line, and we see that for low oxygen, PALI has an accuracy that's consistently less than that threshold up to 16 millimeters, which makes it as a promising modality to sensitively detect metastasis. So in conclusion, I've shown through simulation that the maximum imaging depth that we can achieve is 22 millimeters. However, as many lymph nodes have an imaging depth that's greater than this, we will have to find ways to improve our imaging depth by either increasing the concentration of methylene blue to improve our signal, or we can try to directly deliver light into the lymph node using optical fibers. And with that, I'll open up to questions. Thank you.
Thank you. Dr. Bai, do you have any questions?
So, I mean, I'm not quite familiar with the technique that you're using to detect this. So what's the resolution? I mean, in terms of, you mentioned about like different concentrations of oxygen, but in terms of the size of the, for example, the lymph node, does it matter? Like if it's too small, can still detect it?
So we have the same resolution as an ultrasound transducer. So depending on the bandwidth of your transducer, that affects the resolution. But typical ultrasound transducers can detect between from 200 microns. Around 200 microns is the resolution.
Dr. Corbett?
Thank you. That's a really interesting approach. And I like that's very robust, like it's really well done. So I had a question around, and I found it interesting because that's what I was trying to see, how are you going to kind of overcome some of the limitation that you're starting to identify? And you mentioned, increasing the methylene blue potentially. So how is that actually an option, or is there a risk for the patient then?
So methylene blue is actually a very, very safe. They use it all the time in procedures. I think the maximum is you can go up to millimolars. And the concentration I've been using was hundreds of micromolars.
Okay.
So, but for in vivo testing, was thinking that we could embed it into a nanoparticle, and inside the nanoparticles, we can really jack up the concentration. Because right now they just inject it into the tumor, and so you're subject to the flow distribution of the body, which is
it's likely not very efficient.
Exactly. So with these nanoparticles, we can really jack up the concentration and really improve signal that way. Great.
And my second question was around, we see your system set up on the poster there, and part of me was wondering, how easy it is to then transpose that into an operating room in a way. Is it actually that easily to just carry over, or that's going to also, once you start, being able to use it, will it require redesign too? And can you start thinking about that at the same time as you're going along with looking at using PALI?
Yeah, so what's not pictured is, in order to do this, you have to have two high energy lasers. And so those lasers are big and bulky, which will really crowd an operating room. So, but yeah, we're still trying to think about how we can really make this translatable, how we can make it the form factor, make it smaller. But yeah, right now we're trying to establish proof of concept, and so we're saving those questions we're trying to address those questions later on.
Yeah, no, and I think it's fair, like, which is probably why, I assumed they would be big bulk laser behind, but I didn't want to assume actually.
Yeah.
But I think it might be good you can't just leave it out in a way, because you might redesign at some point. So I'm not sure how it works within your workflow, but it's definitely something to likely keep in mind, especially if it's a relevant technology. If it gets, stubbed just because of the form factor, that'd be a little bit silly, or delayed. I think that's more the delay that I'm seeing.
All right. Thank you, Josh.
Thank you.